Understanding comorbidity. Why PTSD rarely travels alone. Post-traumatic stress disorder, PTSD, is a profound psychological response to trauma. But for many, it is not a solitary diagnosis. Clinical data reveals a striking reality. Up to 90% of individuals with PTSD experience at least one co-occurring psychiatric disorder, and 2/3 of patients manage two or more simultaneously. This phenomenon, known as comorbidity, complicates the recovery process because symptoms often overlap. Patients may struggle to identify the root cause of their distress, or they may receive a diagnosis for one condition while the other remains untreated. Understanding these connections is vital for effective recovery. Substance use disorders, SUDs. The cycle of self-medication, one of the most common companions to PTSD, is substance use disorder. Research suggests that approximately 45% of people with PTSD also meet the criteria for an SUD. The relationship between these two conditions is bidirectional. PTSD as a trigger. Individuals may use alcohol or drugs to numb the emotional pain or hypervigilance associated with trauma. SUD as a risk factor. Substance abuse can exacerbate stress levels, potentially triggering or worsening PTSD symptoms. When people with PTSD turn to alcohol or drug use, they might be trying to numb themselves from their problems and their trauma, says Dr. Tara Imrani, a clinical psychologist. The paradox of self-medication. While substances like alcohol or marijuana may offer temporary relief from insomnia or anxiety, they ultimately sabotage recovery by worsening sleep quality, which is already compromised in PTSD patients, increasing irritability and mood swings, impairing concentration and cognitive function, reinforcing avoidance behaviors, a core symptom of PTSD. Note on veterans. While PTSD rates are similar between veterans and the general population, veterans are significantly more likely to struggle with co-occurring substance use, being twice as likely to have alcohol use disorders and 3 times as likely to have drug or tobacco use disorders. Major depressive disorder, MDD, depression, and PTSD are deeply intertwined, with roughly 52% of people with PTSD also living with major depressive disorder. Unlike temporary sadness, MDD is a persistent state that interferes with daily functioning, often manifesting as hopelessness, fatigue, and recurring thoughts of death. Because the symptoms of depression, such as sleep disturbances and low energy, overlap so heavily with PTSD, the two conditions often fuel one another in a downward spiral. Anxiety disorders. Although the American Psychiatric Association reclassified PTSD as a trauma and stressor-related disorder, in 2013, anxiety remains a primary co-occurrence. Generalized anxiety disorder, GAD, is particularly prevalent. When PTSD and GAD coexist, the clinical outlook is often more severe, characterized by a need for higher medication dosages, more chronic, long-lasting symptoms, a greater difficulty in maintaining daily functions. The constant state of high alert in PTSD can merge with the persistent, uncontrollable worry of GAD, making it difficult for patients to engage in or complete treatment programs. Borderline personality disorder, BPD. There is a significant overlap between PTSD and borderline personality disorder, with estimates suggesting that 25% to 60% of people with BPD also have PTSD. While they share symptoms like emotional instability and anxiety, there are key distinctions. Triggers. BPD triggers are often internal thoughts and emotions, whereas PTSD triggers are typically external, reminders of the traumatic event. Self-harm. This is statistically more common in individuals with BPD. Because of these similarities, particularly when childhood trauma is involved, professional clinical evaluation is essential to distinguish between the two or to treat them as concurrent issues. Navigating treatment and recovery. The presence of multiple conditions does not mean recovery is impossible. Rather, it requires a more integrated approach. Because many symptoms overlap, certain therapies can be highly efficient. Effective modalities include cognitive behavioral therapy, CBT, highly effective for both depression and anxiety by helping patients reframe negative thought patterns. Dialectical behavior therapy, DBT, specifically designed to help with emotional regulation and is a cornerstone for treating BPD. Pharmacotherapy, medications like SSRIs, selective serotonin reuptake inhibitors, can often address symptoms of both depression and anxiety simultaneously. Integrated care, treating PTSD and substance use disorders at the same time rather than sequentially generally leads to better long-term outcomes. Summary: PTSD rarely exists in a vacuum. It is frequently accompanied by depression, anxiety, substance use, or personality disorders. Recognizing these connections is the first step toward a comprehensive treatment plan that addresses the whole person rather than just a single symptom.